Thanks everyone. I'm Kyle Bruin with One Up Health. I lead a product for health plans and really appreciate everyone taking the time today to attend the webinar. So I'd like to introduce our next panel, which is definitely highly anticipated with Denise and Ryan in terms of kind of having some direct access to CMS, which is very sought after these days. So without further ado, I just want to introduce Denise St Clair. She is the senior policy expert with CMS, and she has over 12 years of really rich professional and academic research experience. And she's definitely the right person to answer a lot of these questions that have come up throughout the day today from the previous sessions, and I'm sure more to come later. And Denise, prior to CMS, has done a tour of federal agencies and has served a number of them ranging from CDC, AHRQ, DOD, DOT, just to name a few. So really many of the three-letter acronyms down in the DC area. And Denise received her PhD from University of Wisconsin-Madison and has 5 years of teaching experience there. So that was kind of before her CMS role, but now she eats, sleeps, and breathes the CMS rule itself. So looking forward to hearing Denise's kind of overview from CMS and giving you all in the audience active time to ask her some questions directly. And then Ryan, for those who weren't on the last session, Ryan Howells will be helping moderate some of the Q&A with Denise during this next hour. And Ryan comes from a background of, he's a principal with Leavitt Partners, but really he spends the majority of his time working with the CARIN Alliance, where he's a program manager. And Ryan's been very heavily involved in the Sequoia project, CMS, the FAST project, and to name just a few of the various healthcare interoperability initiatives that are driving things forward in addition to the government. So with that, Denise, why don't you kick it off?
Great, thank you so much, Kyle, and thank you all for having me today. I'm glad to get to speak to you directly. I've been listening intently since we started today, and definitely have some answers to some of the questions that I've heard. So that's great, and it was great to be followed by the previous presentation, because all of that will sort of come into context a little bit here. So I'm Denise St Clair. I'm with the new Health Informatics and Interoperability Group. We affectionately refer to ourselves as High IG. We will be getting t-shirts, just so you know. And we are part of the new Office for Burden Reduction in Health Informatics at CMS. And it's really important for us to highlight that new office, because it's a wonderful opportunity, one, to really give interoperability a home, and it really is a exciting opportunity to be charged with evaluating and overseeing and assisting the agency in a grand interoperability policy, both internally and externally. So that was definitely something that Ryan hinted at, and is very true. You're all very well aware of the CMS Interoperability and Patient Access Final Rule, and that's obviously what we'll focus on today, but it really is step one. It's really a first step in our road to interoperability, and we very much see this as an ongoing road. There's no point where we say, yay, we did it, we're done, we're interoperable. You know, no more work to do here. The bar constantly moves because the technology is going to change, the needs are going to change, the reality is going to change. We'll have a public health emergency that teaches us a whole lot of things we need to know and do better as we've experienced now. So these are all opportunities for us to continue to learn and grow. And this is just step one in that process. And it's absolutely critical that we're agile and able to adapt and move and change with the needs and the realities of the world around us. So when we started on this road, and as you can see, it's an arrow, not a destination. When we started on this road, we really started by thinking about three critical pieces of the interoperability puzzle. First, patient access. Our number one interest and our first step of dedicated interoperability policy was really to focus on empowering patients, liberating the data so that patients could be at the center of their care and they could make informed decisions, and that they had the information they needed when they needed it in a way they could truly use and understand it. So that was one key guiding principle. The second thing we really focused on was connecting healthcare through data exchange. So driving value-based care. We want to get to a world of value-based care versus, paying for widgets, as it were. Then we really need data, and we need good data, and we need the right data in the right place at the right time. And we need everyone to be able to understand, digest, use, and value that data, and that means technology and standards. Getting the data flowing in a interoperable way means standardized data that everyone can consume, regardless of where the data live now or the different types of systems used. So those are three of our guiding principles, but absolutely critical is that all of this is built on a foundation of privacy and security. We don't have a single conversation at CMS about interoperability and data exchange that doesn't start with privacy and security. So that is definitely something that really is foundational and critical for us all to be thinking about. And I know you are all thinking about that as we start down this path together. So if we can go to the next slide. What you are all terribly interested in knowing more about is the CMS Interoperability and Patient Access Final Rule. And you've probably seen this slide, and you may have heard me say this more than once, but this is the one-stop shop for everything that was finalized in this rule. The rule was released in tandem with the ONC 21st Century Cures Act Final Rule. Obviously, we point to a number of the foundational standards that ONC finalized on behalf of HHS in that rule. And really together, the two show a united move toward FHIR-based data exchange. So this is really a department, an agency, a federal government initiative that we are happy to be part of, because it really does help us all get to our most desired place, which is a place where we have interoperable, valued, standardized data that we can all make the most out of and get the most value out of. So we unofficially released the rules in March, ahead of the HIMSS that was not, and we officially published the rules in the Federal Register on May 1st. And really, this is something different for us as a agency, because a lot of times our rulemaking sort of focuses on a single program or a single piece of the puzzle, but interoperability doesn't live in one bucket. Interoperability is inherently collaborative and interactive, and it inevitably touches a lot of pieces. So pretty much everyone CMS as a regulator touches is implicated in some place in this rule. But what we're going to focus on today is payers. What are the policies that impact you the most, and what do we know you have the most questions about? So we're going to really focus on three policies in particular. We're going to focus on the Patient Access API, the Provider Directory API, and the Payer-to-Payer Data Exchange. And even more so the two API policies, simply just because they come online sooner. So, but there's a number of things that overlap, particularly between the Patient Access API and the Payer-to-Payer Data Exchange, that we think it's important to point out, but it's also very important to point out where they diverge. Just because we appreciate that's also some of the source of folks' questions. So we want to make sure we hit upon both of those things. So first, when does all this go down? Well, we finalized in the rule that the two APIs were applicable starting January 1st, 2021. But as I hope you all know, when we released the rule on May 1st, we did announce that we would be exercising 6 months of enforcement discretion due to the public health emergency. So we will not be enforcing these API policies until after July 1, 2021. So 6 months of enforcement discretion on the two API policies. The Payer-to-Payer Data Exchange is applicable starting January 1, 2022. So that's when. Who is impacted by these policies? The Patient Access API is applicable to all of the CMS regulated payers that we call out in the rule. So the impacted payers, and we use that term a lot. So when we say the impacted payers for the Patient Access API, we mean Medicare Advantage organizations, Medicaid and CHIP fee-for-service programs, Medicaid managed care plans, CHIP managed care entities, and qualified health plan issuers on the federally facilitated exchanges. So that's the suite of payers that are implicated for the patient access API. So the provider directory API, it's the same cast of characters minus qualified health plans. QHP issuers are the only payers that, of that set that do not have to meet the provider directory API. And that's because there's already requirements for the QHPs around exposing some of the provider directory data. For the payer-to-payer data exchange, the payers that must abide by that policy, it's again Medicare Advantage organizations, Medicaid and CHIP managed care, and qualified health plans on the individual exchanges. So the payer-to-payer data exchange was not finalized for Medicaid and CHIP fee-for-service. It was finalized for Medicaid and CHIP managed care. Now, as we mentioned, and we'll continue to say, this is the first step. So in this first step, the approach was to really kind of focus for fee-for-service, understanding the unique realities of states, the attention on the API pieces of the puzzle. But we will continue to move forward down this path, so just something to keep in mind. So that's the what, or the when and the who. So now you want to know what. What do you have to do here? What's required? So we're really going to start by focusing in on the patient access API, which obviously is the primary focus of a lot of what you're hearing today. So what did we actually require in the rule? We required the impacted payers to implement, test, and monitor a secure standards-based API, and that's a FHIR Release 4.0.1 API that's accessible to a third-party app for use by a patient. So this is a patient-directed data sharing. Your patient, if you're a payer, your patient, your enrollee, your member, your beneficiary, everybody uses a different term, will find an app in an app store, and perhaps they're a patient with diabetes, and they want to find something to help them manage their diabetes. So they find an app that meets their needs, and they go into that app and they agree to the terms and conditions, and they provide information about their current payer, and that then will trigger your API being pinged by this third-party app. And what are the kinds of things that we see? And again, we have Blue Button to look to. Obviously, our Blue Button 2.0 at CMS, which makes Medicare fee-for-service claims available to Medicare beneficiaries, is our sort of guiding light here. And we see that there's all kinds of wonderful things that these third-party apps are able to do to give data back to patients in a way that they can really use and really make their care better as a result of having in front of them. So what kind of data are we exposing here? Well, we require that you, at a minimum, make available adjudicated claims, including cost, encounters with capitated providers, provider remittances and enrollee cost sharing, and clinical data in the form of the U.S. Core Data for Interoperability, or the US CDI version 1. And again, that was something specified and finalized in the ONC rule. So that's the floor. That's the minimum amount of data that you have to make available. We do note this includes vision and dental claims, if that's something that is part of your plan. And for Medicare Advantage plans that include a prescription drug benefit, they also have to make prescription drug claims available and formulary data available. And Medicaid and CHIP programs, fee-for-service and managed care, have to make preferred drug lists available where applicable. So we're talking about the buckets of data that Ryan mentioned earlier. We're talking about claims data, which you're all amazingly familiar with, a subset of clinical data in the form of the US CDI, and the formulary information. Now, in order to support digging deeper into each of those types of data, Ryan did mention that we suggested, did not request, but strongly suggest that you consider looking at a set of implementation guides. And at the end of this presentation, which I'm sure you will all have access to, there's a link to a website which provides a lot more information about those implementation guides and where you can go to get more information even from there. But Ryan already showed you the specifics. It's the CARIN IG related to the blue button data. That's for your claims data. You have two options that we suggest considering to expose the US CDI data. Originally, we noted the US Core IG, and as part of the implementation process, we're always listening to you, and we're very open and willing and able to continue this conversation. We're all going down this road together. So for instance, the payers came to us and said, you know, we understand why you suggested the US Core IG, but actually there's a couple of extra things in the Da Vinci PDEX IG that we'd really like to expose, and we really appreciate how Provenance is formulated within PDEX versus in the US Core IG. And of course, Provenance is one of the data elements in the US CDI. So appreciating the overlap between the US Core IG and the PDEX IG, and understanding the interest of payers, we did add PDEX as something to consider, as an option to consider for exposing the US CDI for the subset of clinical data that are required to be made available. And then there is the PDEX formulary IG, which is the IG we suggest to help expose the formulary data. So those IGs can help you sort of dig into the details for the folks that want to, really drill down and say, well, when you say claim, what do you mean? And when you say formulary, what do you mean? So that's a guide to look to there. Some important things that we hear as we go here. We know you have lots of questions, and I definitely want to try and hit on the big ones as we go. Around claims data, when does the clock start? So the rule requires that payers make available claims and encounter data with a date of service on or after January 1, 2016, and that those data be made available 1 business day after a claim is adjudicated or encounter data are received. So the clock starts with adjudication for claims and receipt for encounter data. So we appreciate that it may take some time, depending on how your adjudication process works, for the claim to sort of get to you, and that's okay. But the day you get it, that's when the clock starts. So that's an important piece. Something else that we learned was that the word encounter doesn't mean the same thing to everyone. So when we say encounter data, we're really seeing this as synonymous with claims. So this is really information or data relating to the receipt of any item or service by an enrollee under a contract between a state and a Medicare plan. So encounter is often used in that context. So that's really what we're talking about here. But in both cases, claims and encounter, we're thinking that CARIN IG, that EOB resource is really where you're focused. We also say that you need to make a subset of clinical data available, so the US CDI data. And we know you have a lot of questions about that, and we heard this from the presentations earlier, that that's the piece, you got claims, but the encounter data or the clinical data is definitely something newer to focus on. So the final rule says that payers must make all the data they maintain available that fits within the parameters of the requirements for the US CDI and claims data. So what do we mean by maintain? And this is a really, really important point. What we mean is that the payer has access to the data, control over the data, and the ability to make the data available through the API. So access, control, and ability to share. It is really important for payers to assess your system. Everyone is different. We've got a lot of folks impacted by this rule. And so making sure that you're doing that assessment and in good faith, making the information available that you maintain per that definition. And this then raises the question about that unstructured data. So we heard this a bit this morning, so that we know, and we've heard you and we are listening, that there is a concern about, say, those 100-page PDFs or those large scans of faxes that you do maintain. They're within your system, but they're unstructured, and you can make an assumption there might be a data element implicated by the USCDI in there. But the question is, do you need to open them, manually pull out each one, and map that to FHIR? That is something that, appreciating the feedback that we've gotten and the concerns you have, we are taking back and evaluating, and we are in an active moment of discovery on that to find the best middle ground we can to meet the letter of the rule, to make the data that you have and that you maintain available, but to do it in a way that makes sense and meets the ultimate goal here. Our goal here is to help patients get access to data that they really can use. And if an app is going to be able to take data and turn it around and put it in a format that really a patient can understand and use, we need those data to be in standardized data elements, not PDFs of all kinds of stuff. So that's what we're looking at now. We're always open to your feedback. We do plan to get you feedback on that as soon as we possibly can. But in the meantime, if you've got an opinion and you haven't shared it, we are happy to hear. And you can always reach out directly to us. And also on the website we give you, there is a link for an email address. And I apologize, we are not the quickest in responding. We're a small but mighty team, but we are constantly working on it. So forgive us for a delayed response, but we are paying attention. So the USCDI and the unstructured data piece, we know this is a concern for you and a question for you, and we are working through that to try to find the most desirable starting point for all of us to get to our ultimate goals. So definitely wanted to make sure that that was on your radar. Another thing we hear a lot about, especially when we're talking about the USCDI and the clinical data with the date of service of January 1, 2016 forward, is about a quote unquote look back period. We don't really call it a look back period because that can make it feel like it always is the same. So it really is a starting point. Again, I mean, and I'm sure if you've heard the administrator of CMS, Administrator Verma, talk about interoperability, you have heard her talk about her desired goal for patients. She would like the payer to ultimately, in the ideal state, be the one to maintain a longitudinal record for the patient. From birth to death, our data follow us, and our data carry through with us as we move throughout the healthcare system. We have a lot of providers throughout our care journey, but we often have one, maybe two payers who are part. Now, we can move around as patients. We all have our different patterns and our different realities that impact that. But that holistic constant, that ability to, as a patient, always have that information, that ability to support care coordination and support care continuity is so critical for our health and for our move to value-based care as an industry. And so that's really what we're working toward. But we had to start somewhere. And the way the proposed rule was written, a little bit, some of you noticed in your public comments that technically, if we hadn't set a date, would have been on the hook for data for all time. And we appreciate that would have been a big lift. And we already note in the final rule that the biggest lift of getting this rule up and running for you is preparing the data to be shared, mapping the data you currently have to FHIR and making it available via the APIs. So we sort of split the difference there and said, okay, we have to start somewhere. Patients really wanted all of the data, just FYI. But the date we chose was 2016. So when we start, it is 5 years, but that's just to start. it will remain 2016 as we move down the line. So that said, if a patient is a current patient, and this is critical because the Patient Access API is only available to your current patients. If a current patient comes to you in 2035 and they've been with you since 2014 and they use an app and ultimately you're paying for their data to be shared through the Patient Access API, they would be entitled to all of the data that you maintain in terms of claims and the USCDI data with the date of service of 2016 forward, so 2016 through 2035. So the date of service of 2016 is really 2016 forward. And this is, again, is to help build that longitudinal record. It's not their whole record, it's not all of the data, it's the specified data and in the FHIR format. So that's something we wanted to make sure to put to make nice and clear. Another thing gets to a question that came up earlier, and that's around testing and vetting. So now you know what data you have to make available through these APIs. You know who has to make these data available. And now you're really wondering about the third-party apps that are going to come knocking on your door. And so as, you know, Ryan and our previous presenters have pointed out, you know, we don't expect you to get run over by millions of apps to start, but we do know that there's lots of vendors doing really wonderful things. And again, we can see that in Blue Button in particular, and you know, that is a great list to go look at. You can go on the Blue Button 2.0 website and see all of the apps that are currently providing opportunities for beneficiaries to get their data through Blue Button. So you can see the kinds of apps and sort of the number of apps. Interestingly, and I think it was just yesterday, this was a question that came up earlier, the Pew Trust released a new study about patient access to data. And not surprising to us, there was an overwhelming interest in patients getting their data and getting electronic access to their data. So we know patients want this. We know there's apps out there that are eager to provide this service to patients. But we know you're also concerned about privacy and security. So a really critical piece of this puzzle is that you can only deny access per the final rule to an app that presents a security risk to the PHI on your system. That's it. If a patient says, I want my data to come through an app and it's not a security risk, it is their right under HIPAA and under our programmatic authority to be able to get access to their data. So a couple of things. Is vetting, and I'm using air quotes, allowed? And you know, Ryan said it, no. In the sense that you can't deny someone access. Do we really care about privacy and security? Absolutely. And do we know that you do as well? Absolutely. And do we know this is a new world for patients? Absolutely. So there's a couple of things that we put in place to provide some additional tools to support you here and to support patients. One is the requirement that all payers make educational materials available to patients about the reality of sharing their data through a third-party app. And again, on the website link at the end of the slide deck, there is information about things that you as a payer can include in those educational materials. So you can pull straight from that and then tailor to your patient population. But one of the big things we focus on is what to consider when you're choosing a third-party app. What are the kinds of things that you should worry about? So those educational materials are one piece of the puzzle. Another piece of the puzzle is that we finalized an option for payers to request third-party apps to attest to certain privacy provisions. It's not a requirement, but it's an opportunity that is allowed to you. So you could request that a third-party app attest to certain things, such as secondary uses of data. What else will you potentially do with the data? What other data might you access from a patient's device? So location data, for instance, contacts, that kind of information. You could require your apps to attest to having a privacy policy that is easy to understand, plain language, and front and center. And along those lines, we do point to the CARIN Code of Conduct. We do point to the ONC Model Privacy Notice. These are wonderful resources to use to point to as the gold standard for privacy policies for these apps. And so these are things that you can ask the app to attest to. Now, the app could not respond. The app could respond in a way that does not indicate that they are in fact willing to attest to these things. In those two situations, this privacy policy attestation would allow you to sort of say to the patient, you know what, we asked the app vendor to attest to these specific things and they didn't, or they didn't attest positively. And at that point, the patient would have an opportunity to say, you know what, never mind. Or to say, that's nice, I still want you to send my data. And because it is the patient's right, and because they have already authorized the app to get their data, you do have to make those data available, even if that attestation isn't positive. So that's a really important piece, but it's also important for you to realize that that attestation is an option.
Denise,
can
I ask one follow on there? Sorry to cut you off.
Sure.
Yeah, that's really helpful. I think you've been asked that a million times, and yeah, you've been very clear with your answer. So when you say about when an app poses a direct security threat, at what point does the health plan realize that? Is it after the app has registered, they're already live, and then like when and how does the health plan kind of determine that when they can reject an app?
So that's something, the security analysis that payers are currently doing under HIPAA, and it's for the policy wonks in the room, that's under 45 CFR Part 165 Subpart C. So it's the security protocols and the security analysis that you're currently doing on your systems under HIPAA. That's a great framework to continue to use. And OCR, we actually worked with OCR on this, and their suggestion was that process to assess the security of your system be in place as APIs are working to, as your API is working to link to the app. So using those protocols and that analysis, you will be alerted to potential red flags. And so in the process of authenticating, and again, this is an important piece of the puzzle, we do require that the API and therefore the apps, in order to be able to connect to your API, use the security protocols and the security standards as finalized in the ONC 21st Century Cures Act Final Rule on behalf of HHS. So these include things like OAuth 2 and ID Connect. So these are some of the sort of foundational pieces to help assess security, to help in the authorization process, to make sure the proper tokens are being requested, received, and put in play. And so using these tools and relying on your experience with your HIPAA security analyses, your HIPAA compliant security analyses, this will give you the information you need to help you move forward in that. But good question, and a question we get fairly regularly. But anyway, the big bottom line here is that it is the patient's right to get these data. And the only reason you can deny access is the security of the PHI on your system. So want to be very, very clear. But that said, you have the privacy policy piece of the puzzle, you have patient education, and then you have your security analysis. And then in terms of testing, and this gets a little bit to the where else do we go question, and Ryan gave the same answer I would, which is HL7 is a wonderful community. CMS didn't sort of wake up one morning and say, hey, we've got an idea. We're going to make everyone do this. Industry told us this is the direction we want to go. And as Ryan mentioned, you know, the Blue Button Developers Conference and sort of listening to industry on what is the next steps into interoperability and data sharing. These are the desires that really came out of the community, and the HL7 FHIR standards are community-based open source standards. And so we are following industry's lead here. And those industry work groups are wonderful, wonderful opportunities to find a community of practice to work with, and everything from the Confluence pages and the Zulip chats and the Connectathons, which we cannot recommend enough as an opportunity to actually test your software, but not only test your software, but be in the same room as the folks who wrote the code for all of these APIs to answer your questions. And if that is not an option to you, we say reach out. Reach out to us at CMS, reach out to me. We will connect you with our FHIR experts and help you in this process of, you know, finding testing partners if that's something that you need. And we do, on the website that we provide, where we have the information about the implementation guides, we also have reference implementations and test data. And so, you know, we just participated in a Connectathon last week. It was last week, right? it all runs together these days. That HL7 put on. And we were, you know, sort of always happy to see that in the formulary track, in the DaVinci PDEX formulary track, a payer came in with software that they had previously only tested against the reference implementation using the test data made available on that website. And it worked first try when they actually worked to test it within the Connectathon. So that was a wonderful way of sort of saying, hey, those resources are great places to start. But definitely connect with the community, because they're there and they are wonderful. And they are a great resource, and they're in the same boat. So they'll have lots of information to share. So that's definitely a huge piece. I want to make sure they sort of take a step and go, okay, so this is the patient access API. We know what we need to share. We know who needs to share it. We know what data. We have sort of the basics there. A lot of folks then go, well, how does that relate to the payer-to-payer data exchange? I know the payer-to-payer data exchange doesn't take effect till a year later, but what else is similar or different? Well, what's different, one thing I mentioned, is that it does not impact Medicaid and CHIP fee-for-service in this first year. So that's one thing. Of course, if a state really wanted to, they could go ahead and take part, but they're not required. It does not require the use of an API in this first year. We did signal in the final rule that we are continuing to think about that, and that we do reserve the right to consider an API for this. And we also strongly encourage payers to consider the use of an API for this data exchange. So that's something to think about, but it is important to realize it does not require the use of an API to start. The payer-to-payer data exchange also, in this first iteration, focused on just the USCDI data. So at the patient's request, it's all patient-directed. The patient access API and the payer-to-payer data exchange start with the patient requesting these data to move. So a current or former, that's also different. Patient access API is current enrollees only. The payer-to-payer data exchange, a current or a former enrollee can come to you and say, I would like you to send my USCDI data with a date of service of 2016 on to payer X. And that could be, say, they're a new payer, they're about to switch payers, or maybe it's a concurrent payer, and it's their call. So the patient can tell you which payer they would like you to share data. Current patients, that's, you know, a little bit obvious. It's very similar to how it works with the patient access API. For former patients or former enrollees, it's up to 5 years after disenrollment. So you would basically need to hold on to their USCDI data for 5 years after disenrollment. That's actually a lower number than your current data retention policies under all of the implicated CMS regulated plans. But that's a critical piece there. So it is current and former enrollees. So the similarities, 2016 data forward, USCDI data. The differences, or key differences, current and former enrollees for patient, the payer-to-payer data exchange versus current only for the patient access API, and obviously CHIP and Medicaid fee-for-service not being implicated by the payer-to-payer data exchange. And I just said API, but I meant data exchange. So those similarities and differences, I think, are important to try to point out for folks. I want to leave plenty of time for questions, so I'm going to move to the next API policy, which is the Provider Directory API. Now that again was finalized to be applicable January 1, 2021, but again, we are enforcing 6 months or exercising 6 months of enforcement discretion, so we will not enforce the Provider Directory API until July 1, 2021. The Provider Directory API is required to be a public-facing digital endpoint on the website of a payer, which will allow for public discovery and access. So this is different. This is a truly publicly accessible endpoint. And the reason for that is that the Provider Directory information we're talking about is information that, for the most part, many of you already have publicly available. And this is the basic Provider Directory information. And again, as always, the regulation sets the floor. You are more than welcome to go above and beyond, but you are required through the Provider Directory API to make available at a minimum provider name, address, phone number, and specialty. And for MA plans that have a prescription drug component, you're also required to make provider or pharmacy directory information available. And so these data need to be made available within, basically starting in 2021 and then updated within 30 days of you getting either new information or updated information. I will point out for folks who are part of Medicaid and CHIP that there are a few extra data elements implicated, because ultimately, for all of the impacted payers, it's the same information that you're currently required to make available in your provider directories. It's just changing the format. So it's ultimately just making it API enabled. And that, again, is probably a critical point to make across all of this. All these data are already accessible and moving. The difference is the use of the FHIR-based API and all the benefits that that brings with it. So we do require that payers exclude the security protocols related to user authentication and authorization with the Provider Directory API, because the goal here is to in no way restrict the availability of the information to anybody wishing to access it. This is not PHI. This is publicly available information. And so those restrictions were not considered necessary for inclusion. We do strongly encourage looking at the DaVinci PDEX PlanNet IG for this information. And for those of you who are part of Medicaid and CHIP, you may have noticed that the recent Medicaid State Director letter actually required the use of the PlanNet IG for certain funding opportunities. And we strongly encourage all Medicaid and CHIP participants to look at that most recent Medicaid State Director letter related to the interoperability rule that came out last month, because it provides some great resources and information to support implementation of this rule generally. But that was a unique piece there. Another thing we do get a bunch of questions about when we ask about the Provider Directory API, besides the very much publicly accessible endpoint, is for the pharmacy piece for Medicare Advantage prescription drug plans. Similarly to the non-pharmacy piece, it is name, address, phone number of the pharmacy, but also the number of pharmacies in the network and the mix of pharmacies. So really what this gets at is type of pharmacy. And there are some resources available looking at, again, that plan at IG to help you use available resources, FHIR resources, to indicate, is this a retail pharmacy? Is this a compounding pharmacy? Is this an inpatient hospital pharmacy, a mail-in pharmacy, et cetera? So that's what we really mean by type. And so we're always happy to sort of dig into the details more with folks if they have those kinds of questions. But those are the basics of the provider directory API. So I'm going to stop there. And I'm going to guess there might be a question or two, or at the very least, Ryan probably can come up with one or two. What do you think?
Certainly had them in the past, right, Denise? We had an interesting question here around formularies. You had mentioned, does the formulary data need to support just queries about a specific drug, or a broad query like, quote, give me all tier 1 drugs, or even give me the entire formulary in one request?
So again, a great way to sort of look out, the best way to get this data out there is to look at the TDEX formulary IG to see sort of the ways, the use cases around making the data exposable or exposed. One thing I do want to make sure it's really clear, it's current formulary data. Historic formulary data is of absolutely no use to anyone. So we had someone go, do I have to give you every formulary from 2016 forward? No, the patient would lose their minds. They'd hate us. So definitely current formulary data only. And the idea here is to expose ultimately what will be exposable is all the formulary data, because it really does depend on how the app is then going to translate that, right? So, and this is a key point that sort of plays into all of the information here. Your requirement is to make all of these data available to be received or retrieved by the third-party app. The third-party app may not retrieve every piece of this data, but there's no requirement or expectation for the payer to do any kind of data segmentation or any kind of pre-work on a patient-by-patient or other sort of basis. When a patient is agreeing to have their data made available, when they are signing up for that app, they are agreeing to make all of the data available. So that's just a key piece of the puzzle, because there isn't that sort of extra expectation there that we have been asked about. In terms of the formulary, ultimately you're making all of the data retrievable, because it could be a situation of the ability, the app, it makes it able for the patient to sort of say, okay, this is my plan. My current provider just prescribed or suggested 2 different types of, a generic and a name brand of a particular type of drug. I want to go and look, what tier are they in? What would that mean for me in my current situation? And so in that case, it's, the opportunity to sort of look and query those 2 different pieces, which may be in 2 different tiers. So, it's that different level of information. So that's one use case I think, which would be clearly not known ahead to be amazingly specific.
There's a question here, Denise. Realistically, isn't it possible that providers and EHR vendors will find a way to convince ONC CMS to delay beyond July 2021? How much should we trust this date? A little spicy question for you.
You should trust this date. Here's the thing.
Hey, Denise, let me tell you the form of the question we get this in. There's an election in November, right? And there is January 2021 is the date that's published in the final rule. This administration has exercised enforcement discretion. If in fact another administration wins in November, is there any type of likelihood that that date could move? I think that's another way to ask this question, I think, is where it's at.
Yeah, no, there is a commitment at the highest levels that regardless of other factors, that we will not enforce this before July 1, 2021. However, 2021 is the target. And the reason is this: we did literally, the day that we released the rule in March was sort of the first day that I think the US really said, wait a second, there's a problem here, when it came to the PHE. That was actually, I think, the press conference with the administrators started 5 minutes after the stock market closed. So it was really a moment of time of reflection on our healthcare industry. And that morning, there were a lot of discussion of the cruise ships that were stuck for the moment and the question there. And the first thing that came to mind was, if these policies have been in place already, if I'm a patient on that cruise ship and I expected to be away for 7 days, and so I filled in my little medication plastic container with my 7 days of meds, and now I'm going to be quarantined for 14 days. I don't remember the names and the doses. It's the green one and the red one. I don't know what I need. If I had all my information easily accessible on my phone, how much easier would that make even my stress level, if not my ability to do something about this right now in this unique situation? So if anything, the current situation has really made us realize the value of getting these data flowing. And I think that we're hearing conversations a lot more about access to data and patient access to data and public health access to data because of the situation that we're in. So we get questions about, will you delay given the PHE? We do appreciate the unbelievably unique efforts that are going on throughout the healthcare industry, and we've worked to try to address that with some of this enforcement discretion. And for those of you who are implicated by the hospital condition of participation, moving that out a full year to give those frontline warriors opportunity to get a bit of a break. But that said, if we had these policies in place, unfortunately, we know there's a chance there will be a future public health emergency. Having these things in place help us do better and do more. And we do firmly believe in the value of that. So if folks are trying to wait it out and see if this won't come to fruition, I wouldn't say that's a good approach. We are serious about the July 1 for the enforcement.
There's also this issue that we're about to undertake the largest vaccination effort in the history of this country, right? So, and vaccines are definitely something that can be provided as part of this API effort. And so finding ways that every individual understands when they have taken the vaccine, what the vaccine results are, et cetera, is going to be super important. I want to get to these set of questions because we get these a lot too. And CARIN, Denise, can you please comment on how the patient access API should handle information protected by privacy law, including Part 2 data for people on family plans? And there's another corresponding question. How does the data sharing apply to consent rules that require written consent? I'm just going to provide one brief answer, Denise, and then you can correct it if I go astray here. But the expanded question that we get often is, where do the consent rules lie? And does the CMS rule start to get into how to define those? And so what we have talked about with payers is the idea that all of those consent rules in terms of providing access, for example, to other family members, the Part 2 data, all of that is built in behind the firewall of the payer themselves. And that is not touched by our implementation guide or others related to that. That's something that the payers actually handle themselves today behind their firewall. And when they present through SMART that username and password and receive that data, it's just like a portal username and password get, where they're going to get that information, and the business rules attached to that username and password are the same business rules they have behind their firewall themselves, whether it's state specific or federal. And help us amend that if in any way, if I've gone astray there on that guidance.
No, and the most basic way I can say it is that this final rule does not change any of your obligations under current federal, state, local, or tribal law. So Part 2 is Part 2. That stays in place. If you do not have consent to share Part 2 data, then you wouldn't have consent to share it via the API. Like we said, this is the same data moving. It's just instead of handing a piece of paper or a CD-ROM, if folks don't know what that is, it's sending it via the API. So that still is in place and does not change. The same is true, and this comes up a lot when we're talking about the qualified health plan issuers, because we have adult dependents. And so this is very much a state-by-state thing. We appreciate that different states have different laws on this, and those hold true. But generally speaking, if you have an established privacy relationship with either the head of an enrollment group or members of an enrollment group, you need to maintain that privacy relationship when it comes to sharing data via the API. So to Ryan's point, those business rules remain the same. That's something that you've already done within your health plan, you know, in accordance with the existing federal and state laws. And now you need to maintain that moving forward with your API.
You've already answered a lot of these questions. Could CMS require the provider payer DaVinci Fire use cases or Fire IGs in the future? You'd already said that you leave it, there may be a chance that that could happen in the future. I think you'd mentioned that earlier in your conversations. There's some speculatory questions in here that may not be but there's a question about, can the payer request data for treatment from a former payer? And maybe it'd be helpful to clarify the point again you made earlier. When a member requests that their current payer accesses their clinical data from a former payer, then the answer is yes. But the payer themselves can't go out on their own and request clinical information from a prior payer. But go ahead and comment there.
Yeah, under the policies in this rule, so under the payer-to-payer data exchange as it's defined in the Interoperability and Patient Access Final Rule, the exchange starts with the patient's request. So it's only at the patient's direction do data move, either, you know, between concurrent or former or new payers. That said, HIPAA does already allow, obviously, data sharing between payers for various things, including treatment. And so that's data sharing that is currently ongoing, and this, again, doesn't change that. But in terms of this policy is patient-directed.
Yeah, and then I think the final thing here, the final question is about security risk, and you did address a lot of those. I did want to highlight for folks that the ONC rule is pretty clear in their commentary that if an app is following the standards outlined in both the ONC rules and the CMS rule, I can't remember the exact language, but it basically says there is little to no risk associated with how to exchange that information to the actual PHI on an individual system. If you have an API gateway in place, like One Up Health can provide or others can provide, there are an ability for an opportunity to be able to make that happen at scale. And so there's an opportunity to make sure that that data is locked down and is actually secure. Good. I think that's it, Denise. I think we got through most of them here. Christina, Kyle, others, do you have any other questions for Denise?
I think just one other one, I think it kind of gets to some of these similar questions we've had, but one that we've kind of heard a lot is around, yes, it's all or nothing, but is there opportunity to give the member the ability to, let's say it's check boxes, and let's say I want to share my claims, I don't want to share my clinical, or maybe it's some other kind of business breakdown of the data. Is that allowed, that the member can check and uncheck during the consent, or does it really need to be all or nothing?
In this stage of the policy, we really do, it's again, and remember, because it's the member going to an app, finding an app of interest to them and signing up for that app. And so when they're signing up for that app, they are basically saying, I agree to my claims and my USCDI data being made available. That extra step of a level of sort of segmentation or manipulation by the payer is not part of the current rule.
And I will say Argonaut's doing some good work on what they call granular consents. Again, not part of the rule, but it's some additional work where potentially a consumer can actually do that more granular level of consent potentially in the future as an option. So